thank you for having me here. It's a big honor to be here, and the plan exists since last December, Daniel, as far as I remember. And it was tricky to come here because the German Lufthansa is on strike. So I drove to Berlin, from Berlin to London, from London here, and the way back is even more difficult. So I'm happy to be here anyway. And I'm the rookie in this team because we endoscopic surgeons, we are new in this navigation field. And what I want to do is to give you an idea what does it mean to work endoscopically on the spine, and how it could be helpful and important to use navigation. And I prepared a little lecture, and if we can start with the lecture, with the first slide. Hello? Yes. So, next slide, please. My question was, is it trendy or is it mandatory to navigate in endoscopic spine surgery? And I will give you the answer at the end of my presentation. Next slide, please. First, my disclosure is I'm working for the Gymex company as a faculty, that's all. Next slide, please. So, the first question in the audience is, what do a pedicle screw and a spinal endoscope have in common? Next slide, please. They should hit a target. And endoscopic surgery is, compared to screwing and rodding, also target surgery. If we miss the target, we miss the whole thing. So it's very important to hit the target. And how are we doing this? Next slide, please. There are two ways to enter the spinal canal, as you know, the interlaminar way and the interforaminal way. And the interforaminal access is the most gentle way to enter the spine that I know. And what we do, we save all the back muscles. We don't cut them, we only dilate them. And because of the degenerative spine disease, it's also a problem with stability of the spine. It's a good idea to save especially the multifidus muscles. And on that slide, you see the disease, the way of the disease. The disc dries, it loses height, the foramen becomes narrow, and more narrow the longer the disease happens. And if you want to enter this neuroforamen, you have to be very precise because you have to be aware of the exiting route. So the next slide, please. How are we doing this? In the early 2000s, very clever guys invented this crown tip reamer, and it's very sharp on the tip. Next slide, please. And with this crown tip reamer, press it, please. Click it, yeah. And with this sharp tip in the reamer, if we turn it counterclockwise inside, we preserve the muscles. We don't cut them, we dilate them. And if we attach the bone, we turn it clockwise and then ream part of the SAP. Next slide, please. So, next slide. This is the transforaminal approach step by step. Next slide. We first put in a needle, over the needle a wire, over the wire a rod, and then we dilate the muscles, and then we put in the reamer that is guided by the rods. Next slide. Well, we have to respect the medial pedicular line because behind that line it is getting dangerous because the neurostructures appear. Next slide, please. And this is the ideal setting of the working tube. And I especially show you, I always present the level L5 as one because all the experienced surgeons, they always tell us it's not possible to cross the iliac crest and transverse process and so on. It is possible. Maybe you have a problem in young, tall men. There you might switch to the interlaminar approach. Next picture. And next. This is the ideal positioning of the working tube. Next, please. So the medial pedicular line. And the differences of endoscopic surgery to classic spine surgery, you have much less access trauma, you reduce the intra- and perioperative risks, and you have a faster recovery. But the tip next, please. Because due to the smaller access, you have, while the operation less correct possibilities if you don't hit the pathology exactly. And the outer diameter of these scopes, they differ from 6.3 to 10 millimeters. So this is part of the target surgery. Next picture, please. And that leads us to navigation, because when I started in 2008 with endoscopic surgery, we did surgery on soft tissue problems, but on easy cases on the lumbar spine. But endoscopic surgery develops so fast in the past years that leads us to more and more and more difficult approaches, especially, for example, in the thoracic spine or in the cervical spine. And for that, we need navigation. Have a short look on the navigation, how it is. If you fail with navigation, accident could happen. Next slide, please. And navigation is part of our daily life. We use it in the car, we use it on the bike. They use it even in the sky, in the IS. And the first stereotactic pedicle screw was put in 1995. Please correct me if I'm not right. Next slide, please. So the advantages of the navigation, as we heard, are, next slide, the exact tracking of the instruments and the implants that might reduce the risk of misplacement. Next, please. Next. You need only 2 X-rays to start with the whole procedure. Next, please. Yes. You have a constant view control of the screws or endoscope while you do the procedure. Next, please. And you minimize the approach trauma. Next, please. Especially in difficult areas, for sure, as I told you. And you don't need any C-arm while the procedure. Next, please. And it might increase your learning curve. We discussed about the learning curve. For sure, a spine surgeon should be able to do surgery without help of navigation or computers or robotics. Because in case of an emergency or something unexpected, he should be able to manage the problem without the help of technique. Next, please. But I think it can increase the learning curve. And Roger Hartle did a questionnaire in 2013. It was. He asked American surgeons if they use navigation. Click, please. And only a few surgeons did so in 2013. And then he asked, why? What are the reasons? They told him it's too expensive, you have too many technique in the theater, and so on. And the last question was, if you had the chance to have a cheap navigation, would you use it? And most of them agreed. Next, please. So what are the differences of optical or electromagnetic in navigation? This is optical. You have an optical, you have a camera, you have a tracking, you have a view field, and nothing should be between your camera and your instruments. Next, please. And next. And this is how electromagnetic navigation works. Click, please. First, we have to generate a field, an electromagnetic field around it. It's a box 50 to 50 centimeter with a generator. Next field, please. Then we have to adjust the tracker on the spinous process, as in with the optical navigation. Next, please. Then we have to map our tracker in the spine, and this is the moment we do 2 X-rays. Next step, please. And then we use the sensor wire, and the sensor wire is able to enter the needle, because it's very, very important that the sensor wire is flexible. We do a tip navigation. In endoscopic surgery and EM surgery, we do a tip navigation, not an end navigation. In optical navigation, you navigate the instruments by putting the navigation tools at the end of the instrument. What we need is a tip navigation. And this is one of the main differences between this. Next, please. So the advantages of electromagnetic navigation are, next please, you have no line of sight problems. As we heard, by the lecture of Doniel and all the others, a line of sight problems are a main part of problems that could appear in this theater. Next, please. So we can use rotatable instruments for this reamer, the crown tip reamer, for especially, as I told you. Next, please. And we navigate on the tip because the needle is highly flexible. Next, please. And the equipment, last but not least, is more compact, and the optical navigation. Next, please. So we did a study design. Are we talking serious or not? We had a study, 2 surgeons, me and a colleague, and we did, each of us did 10 procedures, navigated, non-navigated, and then we looked how are we quick, how many attempts we use, and how can we save radiation time. And I show you later on the results. But now, next please, I want to go to the workflow. And we did it already. We put on the patient tracker, we set the mapper, we did the 2 X-rays, the lateral and the AP one, and we did the instrument registration. So what I show you now is how fast it is. I do a lot of workshops with very experienced classical surgeons, and the first thing what they learn is how to put a needle. And trust me, the needle setting in the neuroforamen is for most of them very difficult. And I let them sweat for 1 hour. And then we change to navigation, and they see how easy it could be. This case I present you now, the cadaver, thank you. The cadaver is not so easy because we have large lateral osteophytes, so it's not so easy to enter, but anyway, I will do my best. So what you can see is the tracker, and this is the access needle. And normally the way is you come from a lateral, the patient is prone. On that side, it's headward. This side is footward. And normally you do marking lines. You mark the midline, you mark the laterality, you mark the iliac crest that is here, and then you enter the foramen, the skin incision for excess of L4 to 5 is probably between 12, around about 12 centimeter laterality, close to the iliac crest, and you'll find the way. And let's see, now I put in the needle. Can we have the navigation window? This one, yes. I put in the needle and let it follow. What you see is, now I try to attach the SAP, bone is home. Now I'm on bone. I have to come more interior. And now I missed it again. So let's see. Now I'm in the foramen, and now I can change. I now can do my skin incision. I need a knife, please. Thank you. Thank you, Tim. All these guys have done a great job this morning because we had some electromagnetic interferences here. And so the adjustment was a bit tricky, but everything worked fine. I put in the wire. So the older you are, the more tricky it is to put in a wire in the hole. And then this is the dilator. I'm a little bit jet laggy. So I dilate the muscles and I let it follow its way. Now, here we are. Because of the lateral osteophytes, it's very tricky to enter this foramen because it's more narrow than expected, but I think we've done it. And then I disconnect this. And now this is the crown tip reamer. This is the sharp crown tip. And believe me, this thing is very sharp. And you bring it in, you turn it counterclockwise to preserve the muscles.
Question.
Yes.
What is keeping you from spearing the nerve or running into the nerve or traumatizing the nerve?
What is very important to know the pre-op imaging. If you enter the foramen in the lower part, in the so-called safety zone in the Cambion triangle, you should see in the pre-op MRI the exiting nerve root in the upper part. Normally, in normal patients, it lies always in the upper part. There are only rare cases while the exiting root is pushed down by an herniated disc in the lower part, and in these cases, I would do it on a direct visualization. I wouldn't enter the foramen with this crown tip reamer. I would set a working tube on the foramen, and I would open the foramen with camera view with the diamond burr. Was it the answer?
But you're not doing that here. You're doing it endoscopically. So you don't even have a camera in yet, but yet.
No. Normally, if I do this surgery without navigation, my scrub nurse stands on the side of the leg and has her hand on the leg. We do the whole surgery in general anesthesia without any muscle relaxation, and you have to be 100% sure that the patient isn't relaxed. And if I'm coming too close with the blunt rods and the dilating shields, if I'm too close to the nerve root, the leg will move, and I have to change my trajectory.
Okay.
So this is biological monitoring. You need a sensitive scrub nurse. Is that the answer? Okay, so we proceed. Try to let it run. So the lateral osteophyte mislead us a little bit. Let's see where we are. Can we have the stopper? And let's have a working tube. And let's have a quick look inside. So you have a lot of soft tissue, and can we erase the irrigation? I normally work with the irrigation of 40 millimeter plumbum to 50 millimeter, and then you're normally in soft tissue, and now we will see a lot of soft tissue, and then you have to clean it up. And did you do the white balance? Okay. Okay. Yeah, it's all, sometimes in cadavers you have fatty tissue. And now you're in soft tissue. Now you have to clean it up. That's the part of the, but what I wanted to show is how easy the approach could be. And can we go back to the lecture? So this is the approach, and normally you need several attempts. Next slide, please. And normally you need several attempts. Just next slide. Yeah. You need several attempts to enter this foramen, and endoscopic surgery is done so fast. Next slide, please. And these are the first results. We looked on the procedure time. For sure, the procedure time in navigated surgery is longer than in conventional surgery because we have the setup that normally takes about 9 to 12 minutes. We can reduce the number of trials navigated. And what is most important for our surgeons, not only for the patients, for our surgeon, is that we save so much radiation time. And we irradiate so much in spine surgery that is a very important fact for our surgeons. Next slide, please. So this is the main advantage for me. Next point. Next, please. So to conclude, you don't have the possibilities to correct if you're wrong. Next, please. So next. So you have to be very, very close to the target. If you miss the target, you miss the whole thing. Next slide, please. And because the challenges of spine surgery are increasing, you think at the thoracic spine, you should be as precise as possible. Next slide, please. So our first results are very, very, very promising in sparing radiation time, and further investigations have been done. We are rookies, and we want to learn from you. You are so experienced in screw navigation, and we want to learn from you because it's very difficult. The electromagnetic setup is very difficult. It's a bit weaker, that system, because you don't have to have such much metal in the theater, because the disturbance rate is high, and this was the problem this morning. And these guys here in the theater, they did in the lab did a perfect job. They solved the problem. Next, please. And thank you for that. And so I want to conclude. Next, please. At the moment, we are able to do, next, please. We do an approach navigation and only 2D navigation. We can navigate, next, please. We can navigate the needle, next, please. The guiding rods, next, please. The reamers, next, please. And the endoscope. But sure, what has to come, next, please, is the third dimension, because we want to know in the third dimension where we are in the spinal canal. Next, please. The integration of the imaging, the MRI imaging, and more the MRI imaging than the CT imaging. Next, please. And for sure, the future will be augmented reality. And I wonder how heavy this head-mounted device is. And the next, please. And I think I'm absolutely agree that we develop into roboting, especially with endoscopic surgery. Next, please. So the feeling of navigation, I apologize for this joke, because your optical navigation people, you're doing a brilliant job as well. Next, please. Is next, please. That you feel more free with electromagnetic navigation if it works. But on this, if it works, we are working really, really, really hard. But as you know from screwing and rodding optical navigation, this is a long process, and we just started the process. So give us a little bit time, and I think we will be better from day to day. Next, please. So I think it is definitely mandatory, and I want to thank you for your audience. Next, please. And that's it. Any questions? No questions?
Erik, it's Christoph here. Fantastic talk, as usual.
Hi, Chris.
You're such a master in the technology. We all admire you for that. I have a quick question for you. One area that I really miss navigation, not having it, is in lower cervical pathology. Would you mind just, you talked a lot about L5S1, giving us scary stories of taking out nerve roots and stuff. But in your practice, where do you see the biggest bang for your buck in terms of applications of the navigation?
I think that the biggest advantages are in difficult areas like the thoracic spine, the cervical spine, to the thoracic spine, and maybe in L5 as one, because the foramen L2 to 3, 3 to 4, 4 to 5 are easily to hit without navigation, but especially in thoracics pathologies, it will be very helpful. And for sure, in education, it will be very helpful at the moment. But when we talk later on, if we can include the pre-op imaging, we should use it as often as possible to be used to the process. So if you have the navigation, you should use it. Was it the answer? Any more questions?
We have one more question for you. Hold on.
Thank you. Thank you for your audience.
Eric, it's
Yep.
Terrence Kim. I was just wondering, have you explored robots in this kind of scenario? What it seems like the issue is a little pre-op CT scan targeting the ideal trajectory, having a stay and hold arm to guide your trocar guide wire. This seems like a perfect opportunity to incorporate a robot in this.
I really agree, 100%, 150%. I was so impressed by your lectures, all your robotic lectures, and I think the endoscopic surgery is perfect for robotic. It's perfect. I think it could be a key technique for endoscopic spine surgery. Yes. Yes.